On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
I'm Peter Block for On the Scene Video, and it is Friday morning at TCT 2012 in Miami. We're going over the late-breaking clinical trials, and today we have more interesting trials to talk about. I have a distinguished panel. On the far left is Dr. George Dangas from Mount Sinai. Next to him in the center, although he's never in the center, is Tony DeMaria, editor of JACC. He needs no introduction, and on my immediate left is Deepat Bach from the Brigham and Women's. So I'm going to start with George and the first trial here. So the first trial we're going to talk about is ISAR-DESIRE 3, drug-eluting stents versus drug-eluting balloons for restenosis. The drug-eluting balloon business has sort of been interesting in Europe. George, what do you think this is going to do for us?
It is quite interesting. It's a very organized study in an important clinical question. Let me just explain the platform a little bit. Is in patients who have received the drug-eluting stent with either sirolimus or everolimus or the limus family, and the rare occasions that these people have a restenosis. This is a patient, and then the three options in the study: balloon angioplasty, simple, the drug-eluting balloon with paclitaxel, and a paclitaxel-eluting stent. So they change the drug from a limus to paclitaxel, and they have two ways to deliver it. The results very interesting. Both paclitaxel-based therapies were better than the plain balloon angioplasty, and there was not much difference between the paclitaxel-eluting balloon and the paclitaxel-eluting stent. So it looks like in this very well-regimented study, which angiographic follow-up, I must say, as a primary endpoint, the drug-eluting balloon with crisscrossing the type of drug works well, even for the coronary DES restenosis.
Tony?
Well, I think this is good news. The drug-eluting balloons have looked pretty good in the peripheral circulation, and now it would appear for this population with in-stent restenosis that it's an attractive option because you don't have to use more metal.
I think that's an important point. You don't have to leave more metal behind. I'm going to leave you out of this conversation because I want to come to you for the next trial, which is the XIMA trial.
Sure.
Elderly patients above the age of 80, should they get a drug-eluting stent? Should they get a bare metal stent? It's sort of a, don't I know the answer to this before we start kind of trial, but nevertheless, I think an important question.
Yeah, I think it's an important population to study. Lots of times patients over the age of 80 are excluded from trials, so I commend the investigators for doing it. 800 patients, so modest sample size. And the overall primary endpoint wasn't statistically significantly different between the bare metal stent and the second generation drug-eluting stent that was examined here. But there was a trend, a p-value of 0.09 in the primary endpoint, and as far as secondary endpoints, TVR, target vessel revascularization, was very significantly reduced, as is consistent with what's known with drug-eluting stents versus bare metal stents. So, I think the data are important. It showed that DS work in patients over the age of 80.
Sort of a little bit like, gee, I knew that before, but whatever. It's nice to know that at least it's a good thing to do.
Well, I guess you could say, Peter, that the elderly population perhaps more at risk for bleeding, and so if perchance bare metal happened to work as well, then you might be able to reduce the need for antithrombotics.
And in fact, in the trial, there's a signal that bleeding is increased in the elderly, so there you have it. George, what do you think about this? Do you agree?
I think the message is kind of, we sort of knew it. There's an advantage on the TVR and perhaps in the repeat MI or something in that range, but you save a little bit bleeding. I think this is a little bit intertwined with, can we cut the obligatory clopidogrel duration after a drug-eluting stent, and perhaps everolimus in the elderly population, because most of the bleeding difference kind of happened after 6 months. So an abbreviated DAPT regimen might go a long ways in the elderly population while still allowing this improved TVR and rates and all that. Because clearly another thing you don't want to do with the elderly is have them shipped in the cath lab way too often.
Yeah. That's true, but Ian, the interesting thing is, once again, we see that even though they may have to have more stenting done or another intervention, mortality is once again not affected by the fact that we go back. Isn't that correct?
this is right, and there was significantly more non-cardiac mortality in the DS group, but at this age you can never really predict which way the non-cardiac mortality is going to go. Yet another reason to select the patients very well and try to, perhaps in patients who are sick otherwise, limit only to unstable syndromes.
So there you go, two trials which at the front end may not have been that interesting. Turns out they're pretty interesting trials. We'll be right back.